They've got better resolution. They've got a better resolution. And when we talk about the low frequency probes, they've got a better penetration. So we always have to choose, what do we want? Are we looking for better penetration or better resolution? We always want a good resolution, but sometimes when we go deep, we need a more depth. So we lose on the resolution part. For example, if you're wanting to scan a hip, the hip joint is a deeply placed structure. So we need a low frequency probe. But if you're wanting to scan something superficial like the rotator cuff of the shoulder, then we need a high frequency probe. So now the probe has got the ultrasound machine has got various parts. We've got a transducer, we've got a beamformer, we've got a receiver, we've got a memory and a display. Okay, these are the various structures which are there in the machine. Now, how are piezoelectric crystals? How are ultrasound beams produced? The ultrasound beams are produced by piezoelectric crystals. Piezoelectric crystals are of two types. It can be synthetic or natural. Earlier, it was only the natural quartz, but now we've got synthetic crystals also available. Now, if you see the probe, if you see this probe here, what is this probe? It has got an outer case. It has got two layers of electrodes, and in between these two electrodes are the piezoelectric crystals. Then these electrodes are connected by a wire which passes the electric current. Now, when the electric current passes through these electrodes, a magnetic field is produced which causes the vibration of the piezoelectric crystals, which are emitted. Now, these emitted ultrasound beams, they are emitted in all directions, but all this on three sides, it is covered by a metal casing, which does not allow the ultrasound beams to pass, except on one side, which is the plastic noose through which the piezoelectric crystals allow the ultrasound beams to pass through it. So, though the beams are produced everywhere, they pass out only through this plastic noose. Okay. Now these piezoelectric crystals, this is the cut section of the probe, how they are placed. As you can see here, we've got acoustic lens, we've got acoustic matching layer, we have got these. This is all the backing material, and this blue one is the piezoelectric crystals. So these piezoelectric crystals actually emit the ultrasound beam and are received back by these receivers also. Then there are something known as matrix probe. So what are matrix probes? Matrix probes are probes in which the piezoelectric crystals are arranged in multiple directions. That is in a horizontal fashion and in a vertical fashion. Now, how does this help? Since there are more ultrasound beams which are produced and in different direction, so more beams are reflected back to the probe. Hence, the resolution increases to a much greater extent. So, matrix probes have got more piezoelectric crystals to produce more ultrasound beams and hence more resolution. Now, the crystal thickness decides whether they are a low frequency or a high frequency. If we talk about low frequency, see how thick it is. And if you're talking about high frequency, they are finely cut. So this is how you can remember that high frequency probes are costlier, because if you cut a diamond finely, it becomes more costly as compared to a coarse diamond. So this is a low frequency crystal which is thicker, and a high frequency crystal which are thinner. So how is the tissue interaction occurs? So this is the skin here. You can imagine this is the skin, and the ultrasound probe is kept here. So what happens when the ultrasound probe emits the ultrasound beams? The first reflector is the skin. So some beams hit the skin and come back. Some of them go to a next tissue interface and are reflected back. Then there occurs some refraction also. Means the ultrasound beams get a little refracted also. Then some ultrasound beams are absorbed also. So finally, as the ultrasound beams goes deeper and deeper, there occurs some refraction and there occurs some attenuation. Attenuation means there is a loss of ultrasound beams and hence the image quality at the lower end of the screen reduces. So now if I can explain it, if you can all see my hand here. Can you all see my hand?
No,
Yes?
madam,
Or
not visible. No,
can you see it?
not visible. One
Not
minute, I am
visible.
starting your camera. You can
Camera.
start your camera. It is off.
Just let me play the video.
Just click on your camera button, madam.
I can't see the camera. Start my video. Now, can you see?
No, no,
No.
आपका वीडियो दिख नहीं रहा है मैडम एक्चुअली में कुछ भी। आप आ तो गए हैं। वीडियो इज नॉट विजिबल टू अस। आपका वीडियो ऑफ है मैम। अब चालू है।
नहीं, वीडियो तो ऑफ नहीं है. Stop share. My video is very much on, but I can't see.
आप दिख रहा है। आप दिख रहे हैं अभी।
Yes. Okay. This is funny. Share. Okay. So now can you see my hand?
हाँ, यस, वी कैन सी
Okay.
योर हैंड।
Okay, now if I place my ultrasound probe like this, so what happens? The first layer which comes in contact with the ultrasound beams is the skin. So the the skin will reflect some ultrasound beams. The second layer is the subcutaneous tissue. So ultrasound beams are going to be reflected by the subcutaneous tissue. Then the third layer would be the muscles. So ultrasound will be again reflected by the muscles. So every layer the ultrasound beams hit, they have got a different reflectivity which reflects back the ultrasound beams as they are received by the probe. Okay, so that is how the ultrasound beams are produced, and these are produced because of the echoes. The reflected waves are known as the echoes. If more echoes come back to the probe, right? If there's more reflection, then more echoes come back to the probe, and when more echoes come back to the probe, the image is white. Okay, and if less echoes come back to the probe, the image is black. Okay, I'll explain that in the second. So the returning electric signals produce white dots on the screen. The brightness of the dots is equal to the strength of the returning echoes. And location of the dots is determined by the travel time. So what does this mean? So as I told you, when I keep my probe here and ultrasound beams come and hit the skin and come back to the probe. So the skin would be the first structure to be seen on the screen. The second layer, subcutaneous tissue. The subcutaneous tissue would be the second layer to be seen on the screen. Then is the muscles. Then is the bone. So that is how the configuration of the structures on the screen would be. If the structure is highly reflective, then it will produce more white dots on the screen because more echoes are coming back. And if the substance structure is less reflective, like water, fluid, then it will not reflect back any echoes. So the image would be anechoic. So either it will be hyperechoic, that is more echoes coming back to the probe, or it would be anechoic, that is no echoes coming back to the probe. Okay. So what are the different structures? You can see this is a scan over the knee, long axis scan over the knee. So what are you seeing? You're seeing the first, you can see on the top of the screen. Can you see this white structure? That's the skin. All this black area with white strands within. This is the fat, the subcutaneous fat. Now, this is the third layer, and this is the quadriceps tendon, right? Now, how are these structures seen differently? Because the skin has got a different reflectivity, the subcutaneous tissue has got a different reflectivity, the tendons have got a different reflectivity. Then, underneath the tendon, you can see a white structure again. Can you see this white structure? With, and you can't see anything beyond it. That is distal shadowing. So, this white structure is nothing but the bone. Now, this is also white, this is also white. But this structure is bone. Why? Because it is causing distal shadowing. If you have seen, why does your shadow form? Your shadow is forming because when light falls on you, the bones do not transmit the light, and hence a shadow is formed behind you. The same principle applies in ultrasound also. When ultrasound beams fall on a bone, the bone reflects back all the sound and nothing passes through it, and hence you are seeing shadow posterior to the bone. So, anywhere where you are seeing shadowing under a white structure, you should think that we are dealing with a bone. Is this a bone? This is also white. This is also white. This is also white. But I'm saying this is a bone. This is not a bone. Why is this not a bone? Someone can unmute and answer.
Because there is no shadow behind it.
Perfect. Because there is, thank you, Afan. Afan.
Yeah, man.
Okay. Afan, that's a perfect answer. And because, see, this is white, but no shadow, you can see structures beyond it. So that means this is not a bone, but this is just a tendon. Okay. And why am I saying it's a tendon? Because it has got a fibrillar structure. It is attaching to the bone. The anatomy tells me so. Then underneath this, you're again seeing something white, white of different types. Can you see these? There is some whiteness here, some whiteness here, some whiteness here. So all these whiteness are some other structure, other structure. And what is this? Is other structure? That's the fat. This fat is the suprapatellar fat. This is the patella. This is above the patella. So this is suprapatellar fat pad. This is the femur. Right? So on top of the femur, it is the prefemoral fat pad. And then you can see this black area. Now, what is this black area? Is this bone? Or this is fluid? So this is nothing but fluid of the joint. Now, the suprapatellar recess. This is the suprapatellar recess, which is the extension of the joint capsule outside the joint. So some fluid from the joint extends in the suprapatellar region, and this is this pouch. Okay. So now again we are again understanding the different layers. The topmost layer is the skin, and skin is mostly white. Why is it white? Because you need to understand water is always black. Anything which has got more water would be black. Anything which has got less for water will be white. Okay. So anything, if it has got less water, what will it have? It will either have fat or fibrous tissue. So fat and fibrous tissue are all white until unless they've got a lot of fluid content. So the skin is mostly white because it has got a lot of fibrous content. Underneath that, we've got the fat. Now, these fat lobules, they are bounded by echogenic white lines. Now, what are these echogenic white lines? This is again fibrous tissue. Okay. I told you water is always black. Fibrous tissue is always white. Fat can be black or fat can be white depending on the fluid content. If the fluid content is high, it would be black. And if the fluid content goes down, it would become white. You know what's the importance of this? Can someone tell me this importance? Why? As you know how to read a MRI? Have you learned how to read a MRI?
T1 and T2.
Yes, Saket. So when you read a MRI, whenever there is medullary cavity is replaced by fat, how does it appear? White,
We it more white.
right? White on T1, white on T2. When there is more hemopoietic cells, it becomes black. The same way it applies to ultrasound. When there is lot of fluid in the fat, it would appear black, but as you lose the fluid with aging or atrophy, it starts becoming more and more white. So here you can see in the subcutaneous tissue, it is black. But here, prefemoral fat pad, this is white. This is also fat. This is also fat. Understanding? So this is a very important concept which you need to understand, because when you start doing ultrasounds and you do the ultrasound for elderly people, it will be very difficult to differentiate different layers. As you can see the different layers so beautifully in this patient. But in an elderly patient, all this fat becomes white. Okay. So it becomes difficult to scan because the tissue differentiation reduces. And it even becomes more difficult to do an intervention because the needle is also white and your tissues also become white. So putting in the needle becomes more difficult because of the tissue contrast is lost. This we have already discussed. Ultrasound beams do not travel through the bone. Now, coming back to the probes. The probes are of two types according to their make. Earlier, we had all mechanical probes. Now, what are mechanical probes? The ultrasound, the piezoelectric crystals are mounted on a machine which either oscillates or rotates. Either oscillates or rotates. Now, with this oscillation or rotation, the piezoelectric crystals used to get triggered and emit ultrasound beams. But now mechanical probes are almost getting replaced by the electronic probes, in which the electrodes get stimulated and causes the piezoelectric crystals to vibrate and produce ultrasound beams. So electronic transducers are more sturdy and they don't break easily as compared to the mechanical transducers. But still, we have got a combination of mechanical and electronic transducers in 3D and 4D probes because we need a multi-dimensional view. Okay, so if you are having, if one of you have seen a 3D probe or a 4D probe, you can feel the machine moving within it. That is the mechanical probe, but it has also got a electronic transducer within. So now the transducers are of various frequency. They can vary from 2 to 20 megahertz. Now I told you earlier in the lecture that it is the frequency which decides the penetration and the resolution. So will a 2 megahertz probe have a better penetration or a better resolution? Low frequency probe, 2 megahertz. Will it have a better penetration or a better resolution?
Better penetration.
Thank you. Yes, the 2 megahertz probe has got a better penetration, but at the expense of the resolution, we get a poor resolution as compared to 22 megahertz probe, which has got a very good resolution but cannot penetrate more than 1 centimeter or maybe 5 millimeters. So 22 megahertz probe is used to scan what? Very superficial structures, maybe the pulleys of the finger. Okay, because these are very superficially placed. But if you need to scan your hip joint or your shoulder joint, then you need a low frequency probe. So now one of you might be thinking, what do I buy? Do I buy a high frequency probe or a low frequency probe? So this decision depends on multiple factors. What is your practice? That is number one. Are you into small joints? Are you into small joints means do you need to do this interventions of the fingers? Are you a rheumatologist? If you are a rheumatologist, you will always need to do interventions or in the small little joints of the fingers. So you need a very high frequency probe, maybe 22 megahertz probe. But if you are wanting to do spine mainly, then you need a low frequency probe. And if you are wanting to do a mixture of everything, then you need a multiple frequency probe. That is, you need a high frequency probe as well as a low frequency probe. The standard low frequency probes which are available in the market are of 10 to 12 megahertz. The standard high frequency probes are 10 to 12 megahertz, which are good enough to scan most of your superficial structures, but not very superficial structures. And 3 to 5 megahertz probes are good to scan the deeper structures. So ideally, you should be having at least two probes, a 3 to 5 megahertz probe, which is the low frequency probe, and another high frequency probe of 10 to 12 megahertz probe. Until unless you want to do something very specific, so you need to buy the probes accordingly. Is that clear?
Yes.
No?
Yes.
Okay. So keep answering, otherwise I'll also sleep. I've just come back after a US trip and I am in in that jet lag state. So please don't let me sleep. Keep answering. So the
Clear enough, clear enough. Oh,
transducers are of different shapes. You can see these shapes. Now, why do we have these transducers of different shapes? Because it depends on what area are you scanning, right? So here you can see it is a convex shape. Why convex shape? Because you need it is convex like this. So you need a broader area to be scanned. So like when do you need a broader area to be scanned? When you're doing abdominal scans, right? Because it's a big area. Then we have got linear probes. See, it is horizontally placed. The piezoelectric crystals are linearly arranged. So why do you need this linear arrangement when you're doing a MSK? Because you need flat probe to scan the MSK areas. Then we have got a hockey stick probe. See how small the footprint is. We've got endocavitary probe because these probes enter into a cavity, maybe transrectal, transvaginal. Okay, these are echo probes. What are echo probes? Because you do echo through a small window in the chest, right? You all are mostly an anesthetist, I suppose. Yes.
Yes, madam.
And then you must have all seen how you check the ejection fraction or IVC. So when you do this, you check the ejection fraction of the heart. You see, you place your probe in between two ribs. That is the window. Because if you place your probe over the rib, you will not get a window to scan the heart. So when you are scanning the heart, then you need a very small footprint. Can you see the small little footprint which can fit into a intercostal space? So all these probes have been designed according to the requirement of what area you need to scan. Now the arrangement of the piezoelectric crystals. The piezoelectric crystals here you can see here they are arranged in a linear fashion. So when they are arranged in a linear fashion, the ultrasound beams are emitted in a straight line. So you get a straight image. This is a sectoral probe or a convex probe. Now, what happens? The piezoelectric crystals emit the ultrasound beams and they are diverging. See, can you see them diverting? And this is used to scan deeper areas. So, why? Because here you can see the ultrasound beam is getting diverted, and then when it comes here at the lower end of the screen, it can get reflected and you can see a more area of the screen. Then here it is the echo probe. What happens in the echo probe? See, the ultrasound beams are being emitted from a single point because they have to enter into the intercostal space. right? So, and once they go inside, then they are diverging. So these all probes have got the arrangement of the piezoelectric crystals accordingly. So here, what can you see? Here is your linear probe. So the linear probe produces a square image or a rectangular image. And what are the structures which you can see again? The first layer is, of course, the skin. Then you've got the subcutaneous tissue. And then underneath the subcutaneous tissue, you can see a white line, right? So what is this white line? This is the fibrous tissue. And what is the fibrous tissue here? It's a fascia. Fascia covering the muscle. Underneath that, there is another muscle which you can see, right? And underneath that, you can see again a white layer. And this is what? This is again a fascia covering this muscle and this tendon. And whenever there are two muscles and tendons adjacent to each other, then there's always a bursa in between. What is a bursa? Bursa is a fluid filled space which allow smooth movement of the tissues. When one tissue is moving over the other tissue, then there's always a bursa between them so that the movement is frictionless. Okay, then you can see some black structure right here, which is nothing but the articular cartilage. And underneath that articular cartilage, what can you see? You can see the bone. So that is how you identify the various structures. And this is a linear probe. Now coming over to the convex probe. Now this convex probe, as I told you, is mostly used for abdominal scanning. So here what can you see? The image is formed in a sectoral fashion. Can you see the sectoral fashion? Here you see a smaller area, here you see a larger area. And this is the scan over the liver. So now, when you're seeing the liver, you can see these black areas. What are these black areas? These are,
Arteries.
sorry,
Artery or vein?
artery or vein. Very good. So, what are they? Whether they are artery or vein, you have to decide it according to the anatomy. See, all these. Now, what is the structure which travels through the liver? It is the IVC. Now, these structures are all draining into the IVC. So, these have to be the hepatic veins. Okay.
Yes.
So, that is how you decide what is the tissue. You can also, the anatomy is the first and the most important thing which tells you what structure are you dealing with. Never forget your basics. Never forget your anatomy. The machine comes later. It is only for problem solving. But 90% of your scanning is done in black and white mode only. Now, this is the phased arrow probe, or the echo probe. Now, what is happening in this echo probe? You can see the ultrasound beams coming from a single point and diverting down below. Now coming over to the various display modes. We've got a B mode, that is the black and white mode. Okay, this black and white mode is the most important mode, and 90% of your ultrasound scanning is done in B mode or black and white mode. The rest of the modes which you are seeing here are just problem solving. Okay, I would not be wrong if I say 95% of your scanning is done by the B mode only. These rest of these modes are rarely used, very rarely used. So B mode is black and white. When I say black and white, it does not mean just black or just white. It is in different shades of black. That is 256 shades of 250 shades of 56 shades of gray, which you see in the black and white mode. And these shades are defined by the water content in that particular tissue. Clear? Then we've got the black and white with color. What does color mean? Color means that if you put in color, that means you try to see the blood flow or the movement. Any movement which is happening in that particular tissue would be seen by the color mode, not necessarily blood flow. You can even see ureteric jets. You can also see the pushing of the drug. So any movement which is seen, if you put in color mode, you would be able to detect this as red or blue color. Then there's something known as the motion mode. Motion mode is to detect the motion of the walls. This is mainly used by the cardiologist for the echocardiography. Then we've got Doppler mode. Now, Doppler is of three types. We've got the spectral Doppler, we've got the audio Doppler, and the color Doppler. The spectral Doppler is just to see the spectral traces. Audio Doppler is something what the gynecologists use to hear the sound waves in the fetal heart. Okay, you must have all seen that the gynecologist puts a Doppler over the maternal abdomen and hears the fetal heart. Okay, that is the audio Doppler. And then we've got a color Doppler in which you see the color also and spectral traces also. And last but not the least is the power angio, which is used to detect the very slow flow of blood. Okay, so black and white mode, you can see here. This is the black and white mode, and you can see all the different tissues in different shades of gray. And you are able to differentiate each and every tissue. As I said, this is what is this? A white structure with
Bone.
distal shadowing. So it's a
Bone.
bone,
Bone and cartilage.
right? On top of this bone is a black
Cartilage.
cartilage,
Cartilage.
articular cartilage. Now, cartilages are also different types. You have to be specific, articular cartilage or fibrocartilage. If you're talking about articular cartilage, it would be white because it has got more of water. If you're talking about fibrocartilage, it would be, sorry, if you're talking about articular cartilage, it would be black because it has got a lot of water. If you're talking about fibrocartilage, it would be white because it has got a lot more of fibrous content. Clear? So just don't say cartilage. You have to be specific, articular cartilage or the fibrocartilage. Articular cartilages are between two bones. Okay, and fibrocartilage is also between two bones, but the function is very different. The articular cartilage just smoothens the structure, while the fibrocartilages are to absorb the shock. Can you give me an example of fibrocartilage?
Labrum.
Very good. Excellent. Labrum is one. What is another one?
Sacroiliac joint.
Sorry?
Sacroiliac joint?
No,
No.
no,
Uh,
no,
oh,
no, no, no. Menisci.
meniscus.
Okay. Meniscus is the second fibrocartilage. There are a lot of fibrocartilages, but we would be mostly dealing with the labrums and the menisci, and they are white. And the articular cartilage over the places where the bone is articulating with the joint is black because this is articular cartilage. Now, on top of it, over the articular cartilage, what are you seeing? This is a tendon. Why am I saying this is tendon? Because this is fibrillar, this is echogenic, and the location is over the bone. So generally, what happens whenever there is a curved bone, with my anatomy, I know whenever there is a curved bone, the tendon generally curves over it, covers it like this, right? So this is a tendon. Now, on top of this tendon, now I know that is a shoulder. Now I have placed my probe somewhere here. So what is above this tendon is the deltoid, the thick muscle over the shoulder. So this is the deltoid muscle. Between the deltoid and this supraspinatus tendon, what would be there? There would be a
SAST bursa.
there would be small bursa. And what is this bursa? This is just a potential space between two layers of fibrous tissue which have fluid. Okay. Now, what is on top of this deltoid? There's a facial covering over the muscle. If you have done the dissection, if you know, all muscles are covered by a fascia. Every muscle is covered by a fascia. And if there are two muscles adjoining each other, there would be fascia underneath one muscle and fascia underneath one muscle. And there would be space over it. And in that space, there could be a bursa. Is it clear? Are you awake?
Yes, 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 madam.
Chalo, good. Keep me awake also. So this was B mode. In B mode, that is how you identify. Now, none of you asked me why in this muscle, I said this is deltoid. Why are you seeing these white lines? If you don't ask me, I'll ask you. Come on, quickly. The muscle is all black.
Intermuscular
fibrous
septum.
septae are there.
Yes, these are fibrous septae, and these are nothing but the place fibrous septa in which the muscle fibers go and attach. Just recall your physiology. You have got unipinnate muscle, you have got bipinnate muscle, you have got multipinnate muscle. What are these? There are multiple fibrous tissues in which the muscle fibers goes and attach. Now, what is the importance? Why am I telling you this? I'm telling you this because wherever there is a muscle fibers attachment onto the bone, onto this fibrous tissue, that would be a very susceptible area for trauma. So the trauma generally happens whenever there is a trauma, muscular trauma, it happens at the myofibril junction. Okay. So now talking about the motion mode. So motion mode is, as I told you, to see the motion of the walls. This is the heart, and you're seeing the motions of the different walls of the heart. Then coming to the color Doppler. We've got color Doppler, we've got to see whether there is a, as I told you, it is to detect the flow or the movement. Now any movement can be detected, as I told you. So here you can see these are the hepatic veins. I told you they draining into the IVC. Now one hepatic vein is showing blue color, one hepatic vein is showing red color. Why so?
If the flow
Red
is
is
towards
closer to the
heart,
heart.
this
No,
is
no,
red.
no, nothing. It is not related to the heart or anything. It is
If
related
the
to the probe. Any
blood
movement.
flow is towards
Blood
the
coming
probe
to the
or away
probe.
from the probe.
Perfect. But how do you decide what is towards the probe? Now, where is your probe? Your probe is here, right? So this is going towards the probe. So this is red. Now this is the probe and this is going away from the probe. So it is blue.
Blue.
But these are all venous flow. Okay. Now when we talk about power angio, so this scale, this red and blue scale converts into one scale, that is the red scale, and you get to see more flow, better flow in one color. But now some machines have also got that facility that in power angio also you can see two colors. You can detect very slow flow. You reduce in this, what happens? The PRF, pulse repetition, PRF is a button in the machine. Pulse repetition frequency is reduced to that extent that you can pick up very, very slow flow of blood also. Now coming over to the spectral Doppler. Okay, so this is a color Doppler, you can say. Now, why am I saying this is color Doppler? You can see the color flow and you can see the spectral traces also. You can see the color flow also and you can see the spectral traces. Now, what is the importance of the spectral Doppler? See, it helps you to determine the velocity. You can see the velocity, right? You can see the shape of the wave, right? You can detect the obstructions. You can see is there an occlusion or anything which is happening. And then the most important thing for a pain physician is that it is used to identify artery or a vein. The artery has got a spectral flow, while a vein has got a continuous flow. See, can you see this continuous flow? This is a identification of a vein and this is the identification of an artery. Okay. So the second thing is if you take a deep inspiration and hold, what will happen? There would be complete loss of flow in the vein. But here the vein flow would continue. So whenever there is a question how to differentiate between artery and a vein, how would you identify whether you are dealing with the artery or a vein? Quick.
Artery is pulsating, madam.
No, vein also is pulsatile. Have you seen IVC pulsatile?
Yes, yes.
Ma'am, on pressing with the probe, veins will collapse, ma'am.
Then will be collapse.
Okay. Have you never seen a carotid artery collapsing with your pressure?
Yes. The sound is more loud in case of artery when we give the PW mode.
Yes, you get these spectral traces. This is what you should be identifying. When you get these type of traces, you're dealing with artery. When you're getting a continuous flow, then it is a vein.
Yes.
Got it? So this is the most sensitive way of identifying whether you're dealing with the artery or a vein. not by compressibility, not by thin walls, not by pulsatility. These all can be misleading or misguiding. So we already spoke about red color is towards the probe, blue color is away from the probe. Power Doppler is merging of the red and blue color to detect very slow flow. This is how you detect the power Doppler. And the importance is especially to see the neovascularity, to see the regeneration, to see the microvascularity. For all these things, you use the power Doppler. Now, what is artifact? Artifact is the part of the image which is not the true representation of the image. Okay, so there are different types of artifact. It can be distal acoustic shadowing, distal acoustic enhancement, it could be reverberation, and anisotropy. And in ultrasound, we use all these artifacts for our benefit. How do we use them? Let me tell you. So, what is distal acoustic shadowing? I have been speaking about distal acoustic shadowing from the first slide. Whenever What does distal acoustic shadowing means? Distal means behind, acoustic means sound, and shadowing means shadowing. So whenever there is a shadow posterior to a structure, we call it distal acoustic shadowing. And this typically happens when we are dealing with strong reflectors. And what are strong reflectors? They are bones, they are calciums, okay, so they are strong reflectors because they reflect back all the ultrasound beams and nothing is passed through it. So here you can see this is again shoulder, and here you can see the humerus, right? Why am I saying humerus? Because you can see this white line and you can't see behind anything behind it. On top of this humerus, you can see a tendon, this white tendon going and attaching. Now, within this tendon, again, you can see some white echogenic white thing which is causing this shadowing. So, what is this? This is nothing but calcium within the tendon which is causing this shadowing. Okay. Now, on top of this is the second muscle, which I told you is always the deltoid. Okay, which looks to be good. So now what has happened in this? The tendon of supraspinatus has got calcium within. That is the calcific tendinopathy. With me?
Yes, ma'am.
Yes,
Why
ma'am.
is why is this not fibers of the tendon? Because it has got shadowing. It is causing shadowing. Okay. Now, if you see this, what is happening? Is this a shadow? Yes or no?
No.
No?
Yes, yes.
Yes,
This is a shadow. This is what is happening. This is a structure right here, and posterior to it, you are seeing a shadow. But this shadow is not this sharp. This is a irregular shadow. Now, what is happening? Understand the physiology, what is happening. Now you have kept your probe, ultrasound probe here. And the ultrasound, you can see these are structures very well, all these structures. But there is a structure here which is lobulated. Can you see it becoming lobulated with echogenic margins, having a distal shadowing? Why is this distal shadowing seen? Is it calcium? No, this is not calcium. Because calcium has got a sharp shadowing. Okay, see the sharp shadowing. This is an irregular, dirty shadowing, and this is because this is nothing but a malignant fibrous mass. Why malignant fibrous mass? Because it has got so much of fibrous tissue that it is absorbing all the ultrasound beams. And nothing is being reflected and nothing is passing through it. Because nothing is being reflected, so it will not become echogenic. And nothing is passed through it, so you are not able to see anything posterior to it. So whenever you see something like this, don't think that you are dealing with calcium. Think about, is it a malignant mass or is it a scar tissue? Is it a fibrous tissue? Okay. Now, again, the case of shadowing. Now we all are anesthetists. Force, tell me what is this structure? Quickly, we're running out of time. 9 baj gaye hain. This is the trachea. If you place your probe over the trachea like this in the long axis, so what are you seeing? This is the linear probe. That is the high frequency probe. You're seeing the skin, the subcutaneous tissue, and you're seeing these are the strap muscles of the neck. Okay. And now this is the anterior wall of the trachea. What are these? White structures. Casting.
Cartilages.
Yes, calcified cartilages or calcified tracheal rings. Now, in between these two calcified tracheal rings, one tracheal ring and the other tracheal ring, there is some fibrous tissue, right? Which is allowing the ultrasound beams to pass through it. And you are able to see till here. So, what
Yes.
is this? This is the thickness of the tracheal wall, this much. Don't think that this is too thick. This will not be even 5 millimeters. This is a magnified image. So this is the thickness of the trachea. And what are you seeing here? This is the air within the trachea. So what does this image tell you? This image tells you that these are the strap muscles. This is the calcified tracheal ring, which is causing shadowing. And this is the intertracheal fibrous tissue, which is allowing the ultrasound beams to pass through it. And this is the air artifact. Remember, put this in your brains. This is the air artifact. Whenever you see air, you see the artifact is like this. Now, this is the gallbladder. In this gallbladder is filled with bile. Now, this bile is all black. And within this black, there's this white structure, echogenic structure, casting shadowing. Now, what is this?
Stone.
Stone. Why calcium? Why calcium?
Because
Because it is
there
having
is
sharp
having
shadowing.
sharp shadow.
If it would have been cholesterol, will it cause shadowing?
No, no.
No. So you need to understand ki why is shadowing occurring? Shadowing is occurring because there's calcium. Cholesterol will not cause shadowing. What will cholesterol cause? I'll show you in the next image. Okay. Now what is this? This is the head of the humerus. Now there's a tendon coming here. Within the tendon, you can see this structure right here. What is this?
Supraspinatus bursa.
Calcification within the supraspinatus tendon. Very good. How about the others? The others are listening or they're all sleeping?
Yes, yes. Not sleeping.
Not sleeping? Good. Now we spoke about distal acoustic shadowing. Now we are talking about reverberation artifact. Now, what is reverberation artifact? When ultrasound beams encounter two strong parallel reflectors. Now, these two parallel strong reflectors can be anything. It can be the needle. I'll just show you. Here, this is cholesterol crystal. Can you see this?
Yes.
This is the type of shadowing which occurs from the cholesterol. This is the reverberation artifact. This is what is happening. This is again the gallbladder. And in this, you can see the cholesterol crystals with some calcification. Okay. Now, this is, what is this? Batao, what is this? Is this similar to this?
Sliding.
Isn't it?
Yes.
So this is nothing but air within a cavity. So when you see something like this, you always think about, oh, is it air? Is this type of shadowing? This is reverberation artifact. This is of air. So remember how air causes the artifact, how cholesterol crystal causes, how calcium causes. Then we talk about anisotropy. This is the most important artifact. And whenever you are starting doing ultrasound, you get to, in MSK ultrasound, there's so much of anisotropy. Why does this happen? You understand the NF physiology. See what happens when this is the structure. Okay. This is the bone. Now, when a tendon comes and touches onto the bone like this, it curves like this, right? Now, if you have placed your probe like this, okay. So what will happen? The ultrasound beam will go hit this part of the probe and or this part of the tendon and come back. But what will happen to this part? This is because this is curved. The ultrasound waves will not hit it. What will happen? They will diverge. So there would be an echo drop from this area. Echo drop means no echoes will come back from this. area. So this area will appear black. And the moment you see it black, your antenna go up. Am I dealing with what? Fluid. Am I dealing with a tear? What happens in a tear? Fluid accumulates. Okay, so whenever you are over a tendon, there is a lot of anisotropy, and you always think that is it a pathology, but it is not mostly. So, how to overcome it? You tilt your probe like this. See, it was like here. So, this is the tendon. You understand the course of the tendon, and you tilt the probe like this, and the tendon which was black becomes white. So, see it here again. So, here what you are seeing, the tendon is white. But the moment you tilt your probe, it becomes black because the ultrasound beams are not coming to the probe. So you need to understand this anisotropy very well, because when you start doing the ultrasound, you're always looking for pathology. Patient has come with shoulder pain. Oh, kahin isko as he got supraspinatus tear, and you start looking for supraspinatus tear. And the moment that you see an anisotropy, you see black tendon and you make it a tear. So this is what happens in an anisotropy. If the tendon is running straight, ultrasound beams goes, hit the tendon and comes back. But if the tendon is curved like this, then what happens? The ultrasound beams hits the tendon and is reflected out, and no echoes come back to the probe. So there is a echo drop. So this is the Achilles tendon. Now in Achilles tendon, this is a normal Achilles tendon, but you tilt the probe, it becomes pathological. It becomes black. ऐसा लगता है it becomes filled with fluid. Okay. Now the next artifact is distal acoustic enhancement. What is distal acoustic enhancement? Enhancement posterior to a cystic area. So why does it happen? Again, try to understand. See, the ultrasound beams are going. They meet an obstacle here on this wall of the cyst and are reflected back. Then it moves into the cyst. Now, what is happening in the cyst? There is no obstacle, no resistance. They smooth freely, move freely. But the moment they come back, come out of the cyst, they come out of the cyst wall here, they start reflecting. And because they start reflecting, there is whiteness posterior to it. So, what does this indicate? It indicates that you are dealing with clear fluid. So the moment you see distal acoustic enhancement, you are at ease that you are dealing with a simple cyst. Clear? So let us sum up the artifacts. We spoke about reverberation artifact. I didn't show you this image earlier, but this is also a reverberation artifact, because when you put a needle into a tendon, you see a lot of needles under it. Has anyone experienced this? Lot of needles under the...
Yes, madam.
Why does this happen? Because it is a strong reflector. And because of the strong reflector, the ultrasound beams keep hitting it again and again. And there occurs number of needles seen posterior to it. How to overcome it? You just tilt the probe.
Change the angle.
Yeah, change the angle. The moment you change the angle, this will go. Then we spoke about distal acoustic shadowing. Here is the shadowing. White structure with shadowing. And distal acoustic enhancement. Black structure with enhancement posterior to it. Then we spoke about anisotropy. See the tendon coming. See the echo drop. Why is this echo drop? Because the tendon is curving down and getting attached to the bone. So what you need to do, you need to tilt the probe towards the insertion of the tendon. So how do you interpret the image? We spoke a lot about interpretation of the image. We know fluid is always black. Tissues are in different shades of gray, and the grayness of the tissue is determined by the fluid content. If there's more fluid in that tissue, it would be black. And if there's less fluid in that tissue, it will become whiter and whiter. Is it clear?
Yes.
And if there's less fluid, what will there be? Fibrous tissue. Okay. So now, why are the walls of the blood vessel black or white? Because they are fibrous.
They are fibrous collagen tissue.
Yes. Now, can you see this white thing within this vessel? What is this?
Yes.
What
Valve.
is this?
Valve.
Valve. Why is
Yeah.
valve white? Because it is of fibrous tissue.
Yeah.
Okay. Now, what is this? This is the fetal heart. Now, what you can see. Now, with my knowledge of the anatomy, see, here comes the play of the anatomy. You know your heart is tilted towards the left. So, what is towards the left is the left ventricle. What is on
Yes.
top of the left ventricle is the left atrium. What is
Atrium.
between the left ventricle and the right ventricle is the
I
interventricular septum.
interventricular septum.
The right ventricle has got what are these?
Right ventricle has got
Chordate and knee.
chordate.
Okay. Now, on top of the right ventricle is the right atrium, and there is a valve here. Which valve is this? Tricuspid valve.
Tricuspid valve.
Okay. Your anatomy tells you this, and your physiology tells you what is the tissue.
Yes.
Always remember, ultrasound is all about anatomy. You should be knowing your anatomy. Okay, if I place my probe here on my forehead, what am I going to see? I'm going to see the skin, I'm going to see the subcutaneous tissue, I'm going to see the frontalis muscle here. And underneath the frontalis muscle, I'll see the bone. Okay, if you know the layers, you will identify them on the screen. If I place my probe in this over here, I should be knowing what are the structures which I'll be seeing. I'll be seeing the skin, the first layer, then the subcutaneous tissue, then the strap muscles of the neck. Then, depending on the location of the probe, I could see the carotid artery. I could see the external or the internal carotid artery. Right? I could see the IVC. I could see whatever structures, the longus musculi, the different muscles. Now, what are the advantages? After speaking so much, you all know what are the advantages. Excellent for evaluation of the evaluation and intervention in MSK. It is very good for dynamic imaging for accurate diagnosis. Now, what is dynamic imaging? You keep your hand like this. This class is for 1 hour or 2 hours? Anshul,
1 hour.
1 hour?
1 hour.
1 hour, ma'am. 1 hour.
1 hour.
9 to 10.
So
You
Yeah.
can complete in 1 or 1.5
Okay.
hour.
10, 15 minutes. 15.
I'll take 15, 20 minutes more. Okay.
Yes,
So
ma'am.
I'll go fast now. So what are the advantages? So what is dynamic scanning? Dynamic scanning means suppose this is your shoulder, right? Now you keep your probe here and patient is complaining of, oh, I've got a lot of pain, lot of pain here, but you're not seeing anything. Now what do? You tell the patient to move his hand back. The moment he goes back or he stretches his hand, you can see, because of the stretch on the muscle, you can see the tendon tear apart. Not tear apart, rip apart because of the pressure. Or what can happen? At times, many a times, if you must have heard over this cubital tunnel, patients say, when I do this flexion and extension, I feel a clicking here. Has anyone heard this clicking or felt this clicking? Yes, no.
Yes, madam.
Yes. So what is happening? The ulnar nerve is
Dislocating.
dislocating. So how can you diagnose? You can just place your probe here and then you do an extension and you just keep it gently so that you don't compress the nerve in its place. Just do flexion and extension and you can see the nerve skipping out of the cubital tunnel. So that is dynamic scanning. Dynamic scanning can be also done for any structure. For example, if you're seeing impingement means there is patient is complaining, whenever I am not able to move my hand over the shoulder. So you keep your probe like this and you don't see anything. You see everything is good. But the moment you tell him, okay, do the activity in which it pains. So the moment he does like this, you start seeing that there is a buckling of the bursa because that bursa gets entrapped under the acromion. Okay, so dynamic scanning is very good. Can be done as an OPD procedure. It is an upcoming technology which we need to be aware of. The accuracy is as good as MRI for extraarticular structures. Okay, it is very cost effective. It is radiation free. It tells us where not to intervene. How does it tell us? For example, now if you are seeing a big bump in your popliteal fossa, okay, and you go blind, and that was a popliteal artery aneurysm, and you were thinking it is a popliteal cyst. If you would have put a ultrasound probe, that would have shown, okay, there's a lot of blood flow in it. Let me not put my needle here. Getting it?
Yes.
So it tells us where not to intervene at so many places. For example, if you think that, okay, there is the patient is having a CRPS, you want to do stellate ganglion block. And the moment you place your probe, you see a big collection here. So what is it telling? Please don't put in the needle. Treat this collection first. CRPS can be dealt later on. So it prevents you from landing into complication provided you know how to use it. And what are the limitations? It has got a long learning curve. It is not as easy as I am telling you. It takes years and years to understand and learn ultrasound because MSK ultrasound is very difficult because of the curved structures. So you need to understand the anatomy, the course, the tendon path, the muscle names of the different muscles, the tendons, how are they crossing each other. The anatomy is gross. Not a modality of choice for intra-articular pathology. The moment you are thinking of intra-articular pathology, you should go in for MRI. Takes longer time than palpation. All those old timers, they just say, okay, I have to go in the knee, I'll just palpate and go. Tuck. But ultrasound takes time. PNDT. In India, PNDT is a big, huge problem. Many of you will not find it very difficult to take the PNDT for the machines. So you have to do some, some manipulations, some negotiations. Maybe you have to ask a radiologist to get the machine registered in his name. And it has got a very poor acceptance in the old timers. When you do ultrasound, you always use a gel. Why do you use a gel? Because you need to remove the air which is in between the probe and the skin. So the gel removes the air interface. If you otherwise, air is a bad conductor of sound. It does not allow the ultrasound beams to pass through it. And the second thing is it can act as a lubricant. But if you don't have a gel, it doesn't matter. You can use water also. You can use betadine also. You can use chlorhexidine also. You can use any lotion also. But when you are going into the OT, you should be using a aseptic gel or aseptic cream. Okay. We discussed about transducer selection, whether we need to go with a high frequency probe or a low frequency probe. You need to decide what is the area of interest. For example, if you have to do your area of interest is a carotid artery. There are two patients. One is me and one is another patient who has got a very thick and short neck. So in my case, the carotid artery would be maybe 1 centimeter deep. But in that other case, it could be 4 centimeters deep because the neck is thick and short. Okay, so you need to make an estimate in your mind how deep is that structure and accordingly select the probe. Not one probe fits everywhere. You cannot say that, okay, I have to do the carotid, so I'll use a high frequency probe. There might be a time where you might need a low frequency probe also. You want to do a shoulder, maybe my shoulder, see this shoulder. You could do it with a high frequency probe. But if you see a shoulder of a German, Germans are, or they've got high BMI. In those cases, you might need a low frequency probe because this deltoid itself would be maybe 2 centimeters thick or 3 centimeters thick. So you'll not be able to see beneath the deltoid. So always think about how deep is my target of interest and accordingly select the probe. Okay. The image interpretation, how do you place the probe? You always keep the patient in anatomical position. When I say anatomical position, it means the position in which you have to examine the patient. You remember in your MBBS days, you always tell the patient to lie in supine, stand on the right side of the patient, and then examine him. The same way it is in ultrasound. The patient should be in the anatomical position, and if the patient is in the anatomical position, the active end of the probe, that is, should be towards the left side of the screen. That is, this is the active end of the probe. This should be towards the left side of the screen. If this active end of the probe is towards the left side of the screen, what will you see? You will see the image as the anatomical location of the image would be the same in the screen also. So what are you seeing here? This is a convex probe, number one. Number two, you are seeing the skin, the subcutaneous tissue, the recti. The probe is placed in the epigastric region. So in the epigastric region, start thinking in your mind. What are the layers? The skin, the subcutaneous tissue, then the linea alba. On the either side of the linea alba are the two recti. Underneath is the liver. Okay. So now since this is a convex probe and the resolution is lost, you are not seeing the recti very well. You're not seeing the linea alba very well, but you know they are there. And underneath is the liver. And this is the left lobe of the liver because you are in the epigastric region. Okay. Now, if you see this, this is the left lobe of the liver, and underneath this left lobe of the liver, there is this ecogenic structure, which is the pancreas. Okay. Now, how do you say this is pancreas? Because this has got the ecogenicity of the pancreas. It has got the C shape of the pancreas. It is lying on the portal bed. Means this is the portal vein and this is the splenic vein. So the pancreas lies on this bed. And the bed is formed by this, and the pancreas is lying on the top. So anything lying over the splenic vein and the portal vein has to be the pancreas. Okay. Then underneath that, what you are seeing a midline mein you see a aorta, and on the right you are seeing the IVC. Now from the IVC there is a vein here. There is a vein which is crossing like this, and on top of the aorta there is a small little black structure which is nothing but the midline celiac artery. How did I come to know all this? Because of my anatomy. I know, okay, this is the structure which should be in the midline. This is the structure which should be on the right. This is the structure which should be above it. This is the structure which should. I just know, okay, this black structure is a vessel. This black structure is a vessel. But what is this black structure? Lying in the midline over the vertebral body is the aorta. On the right side is the IVC. On top of it is the portal vein. On top of it is the pancreas. And on top of it is the left liver lobe. Okay. So that was the transverse imaging. Then there could be the other one. There could be a vertical imaging. That is a craniocaudal. When you're doing craniocaudal imaging, then your probe should be towards the head end of the patient. So if it is towards the head end of the patient, the upper structures would be seen here and the lower structures would be seen here. And if you move the probe right and left, you see them according to the anterior to the posterior. Anterior posterior remains the same. We will always see the skin anteriorly and the deepest structure posteriorly, no matter you place the probe transversely or in the craniocaudal direction. Okay, so image optimization, there are different buttons on the machine. If you have ever used an ultrasound machine, you would understand that image in the book is different and what comes on your screen is entirely different. Why does this happen? It becomes because of the buttons, the numerous buttons which are there on the machine, which you should be aware. It is something like driving a car. So when you are driving not the automatic car, the old car, old timer car, you all must have driven the old timer car जिसमें हैंड ब्रेक होता है, गियर्स होते हैं, चलाई है ना? गियर वाली कार किसी ने नहीं चलाई?
यस यस चलाइए।
Yes, ma'am.
चलाई है ना? तो क्या होता है, एक हाथ से आप स्टीयरिंग पकड़ते हो, राइट, और दूसरे हाथ से गियर चलाते हो. सेम वे अल्ट्रासाउंड में होता है, एक हाथ से आप प्रोब पकड़ते हो, सेकंड हाथ से जो दूसरा हाथ है ना, उससे कंट्रोल बटन्स होते हैं. वो कंट्रोल बटन्स को हिलाना होता है समझ के कि हमें क्या देखना है, और उसी हिसाब से जब आप हिलाओगे तो आपको अच्छी इमेज दिखाई देगी स्क्रीन पे. तो कंट्रोल बटन्स में क्या क्या है? एक तो डेप्थ है, एक गेन है, एक फ्रीक्वेंसी ऑप्टिमाइजेशन है, इमेजिंग मोड्स एंड फोकस है. सो विल टॉक अबाउट ईच ऑफ देम क्विकली. डेप्थ का क्या पर्पस है? टू सी डीप, कितना डीप देखना चाहते हो. फ्रॉम बिगनिंग आई एम सेइंग कि डेप्थ इज डिटरमाइंड बाय द फ्रीक्वेंसी. नाउ व्हाट डज डेप्थ बटन डू? मान लो तुम्हारी लीनियर प्रोब की फ्रीक्वेंसी है 12 megahertz and it can see till a depth of 4 centimeters. Okay, now your area of interest is at 1 centimeter. So what you can do is you can reduce the depth and you can see the upper end of the screen. So देखो अभी हम इसमें थायराइड देख रहे हैं, दोनों लोग थायराइड के देख रहे हैं. तो दिस इज फुल डेप्थ पूरा थायराइड देख रहा है, नीचे का स्ट्रक्चर भी दिख रहा है। अभी हमने क्या किया, माय टारगेट एरिया इज ओनली द थायराइड, तो आई मैग्नीफाई इट एंड फिल द स्क्रीन ओनली विद दिस thyroid gland. See how beautifully I can see the colloid cyst in the thyroid gland. Okay, same image, just the change of the depth, same probe. Okay, so this is what the depth button does. So now, always, how do you use the depth button? Always keep the target area in the center of the screen. If your target area are the carotid vessels, so should they be at the bottom? No. Should they be at the top end? No. They should be at the center of the screen. This is what the depth button does. So always remember, whenever you are doing a diagnostic or an intervention, the target area should be in the center of the screen. It should not be at the upper end. It should be not at the lower end. Now, the same image, this is the target area. Which is the best image you can see? First, second, or third? This. I can't hear.
Second.
Second. Why second?
Middle one. Because
Because
black and white
Outline is smooth.
no, why? Because there is something known as focus. Now
brightness
you no
focus.
focus. जब आप फोटो खींचते हो, आपको मेरी फोटो खींचनी है, व्हाट विल यू डू? टैप करोगे ना मेरे चेहरे पे ताकि अच्छी फोटो आए।
Yeah.
करते हो?
Yes.
Do you,
Yes.
है ना? What are you doing? You're focusing on my face. So the same way in ultrasound also you have to focus. Focus, there is a button, focus, which has to be at the level of your target. The moment it is at the level of the target, you see it best. If it is low, you see this area better. If it is high, you see this area better. But if it is at the level of the target area, you will see that area better. Okay, so focus is very important. Whatever is your target area, your focus should be at that level. Okay, now gain is to see to reduce or increase the brightness of the screen. So this is over the carotid vessel. Is this image good? Is this image good? Or is this image good?
Balanced one good.
Sorry?
Balanced middle one is good.
Middle one.
Why? You're right. Why?
Because of the
So what is
better.
gain? Now let me first tell you what is gain. Gain is the brightness. So
Bright.
here what is happening? Too much of brightness. Now what is happening with too much of brightness? The vessel also has got some debris with it. The vessel should be black, right? Now what you have done, you increase the gain's brightness so much that there's some ecogenicity within the vessel also. Now what is happening here? The gain is too low. The muscle also is appearing black. You are unable to differentiate whether this is a vessel or this is a vessel. But in this, you can see the vessel well, you can see the muscle well, you can see the layers over the muscles well. So this is a good gain. So by the gain only, you can settle what is the best image you want. So now we in MSK ultrasound we do not in MSK, in every ultrasound we do two types of scanning. One is the long axis scanning and one is the short axis scanning. Long axis is in the long axis of the fibers of the muscle and short axis in the short axis of the fibers of the muscle. Okay, so in and then we should know about ecogenicity. So now coming over to the long axis and short axis. See here. Now my probe is in the short axis of the long head of the biceps tendon. You all know what is long head of biceps tendon? It is a long tendon traveling in the bicipital groove. If you don't know, read it because this is not a shoulder ultrasound class. So the long head of the biceps tendon travels like this, straight here. Here in this image, this is the long head of the biceps tendon. Now I can place my probe in the short axis of the biceps tendon like this, or I can place it in the long axis. So if I place it in the short axis, what do I see? I see the lesser tubercle, I see the greater tubercle, and I see the bicipital tendon between these two lesser and greater tubercle. And when I move it in the long axis, I see something like this fibrillar structure. Okay. So what is the benefit? You see it in the long axis, you see it in the short axis. You should never ever make a diagnosis in one axis. Okay. Echogenicity. We spoke enough about echogenicity. The image can be hyperechoic, it could be hypoechoic or anechoic. What is this? Is it anechoic or hyperechoic? Come on. The class is going anechoic. What is this? Good. What is this?
Hyperechoic.
Hyperechogenicity, and it is posterior to the vessel. So it is distal acoustic enhancement. Okay. What is this? Quickly. This. Hyperechoic. White. Which layer? What is this tissue?
Muscle.
Will this be muscle? Where is your probe? Your probe is here, right?
Yeah.
So what would be this tissue?
Subcutaneous tissue.
Skin and subcutaneous tissue. Good.
Yes.
Okay. So always identify it like this. What would be underneath the skin and subcutaneous? This is the muscle. Muscle will be black mostly until unless it's a very old patient in which they have lost all their fluid. No, quickly. Let's. I'm putting my. What is this?
Joint, articular cartilage.
That's white one. White one. Bone.
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 Joint.
What is on top of the bone?
Articular cartilage.
Very good. What is on top of the articular cartilage?
Second bone.
Oh,
Oh, sorry.
कैप्सूल
Capsule.
कैप्सूल होगा ना जॉइंट है
हाँ,
आर्टिकुलर कार्टिलेज के ऊपर क्या होगा कैप्सूल ही होगा ना
Capsule होगा. Yes.
फिर कैप्सूल के ऊपर और क्या है
Muscle.
मसल्स वेरी गुड व्हाट इज दिस
Nerve.
वेरी गुड एक्सीलेंट व्हाट इज दिस इज द आर्टरी
Artery.
Okay.
Yes.
नाउ दिस इज अ व्हाट इज दिस
Bone.
very good now you can see a discontinuity in the bone can you see this
Yes.
this is a stress fracture in the bone
Okay.
and you can see a white black area here can you see this
Yes.
what is this this is the periosteum which has risen up which is generally stuck to the bone and so
Yes.
there is some fluid accumulation here not a fluid that's the blood accumulation okay
Okay.
so you should be knowing what is normal and what is abnormal once you identify okay this is not normal then you think about what is the pathology now what is this this is over the femur
Yes.
articular cartilage what is this tibia femur this is the femur this is the tibia
Meniscus.
very good this is the meniscus fibrocartilage that is the fibrocartilage echogenic that's black that's the articular cartilage okay now synovium what is synovium come on tell me
Joint space.
every joint is covered by a capsule we all know that
Yes, ma'am.
yes or no
Yes, ma'am.
so the capsule has got two parts the outer part the fibrous part which is seen white and the inner part is the synovial part which is not seen the function of the synovial part is just to secrete a little amount of synovial fluid and the outer whiter part which is seen on ultrasound is the thicker capsule which supports the joint holds the joint in its place but whenever there is synovial hypertrophy means the synovial gets inflamed it becomes frond like this okay now where is the capsule is this okay and this is the synovium which has got hypertrophy that's the bone getting it
Yes.
so whenever you see something like this is nothing but synovial hypertrophy and this is the synovial effusion whenever there's hypertrophy it will secrete more fluid so whenever there's inflammation there would be more fluid where does the fluid comes from the synovium where is the synovium it is the inner lining of the joint capsule Okay. Sometimes this synovium is also around the tendons. For example, the long head of the biceps tendon, because it has got a intra-articular origin. We will talk about it in the shoulder ultrasound class. Now we are running short of time. So this is a muscle. It is a bipinnate muscle, which I told you. See, can you see a central pinna? Muscles coming from here and here coming and attaching. Okay.
Yes.
No, that's a bipinnate. You can have a unipinnate or you can have a multipinnate muscle. Can you give me example of a multipinnate muscle?
Subscapularis.
Subscapulary.
Very good.
Deltoid.
And very good. Excellent. And now this is white structure is the bone. What is this on top of the bone?
But
Tendon.
Excellent.
and
We all know that this is
Fluid.
cyst,
cyst,
right? What is this? Echogenic structure connecting bone to bone.
Ligament.
Very
ligament.
good. Ligament. Ligament are the structures which connect bone to bone. That is how you differentiate tendons and bones, tendons and ligaments. Tendons are structures which connect muscle to the bone. Okay. Clear?
Yes, ma'am.
Tendons are structures which connect muscle to the bones, and ligaments are structures which connect bones to bone. So if you're seeing a structure between bone to bone, always think about ligament. But if you're seeing a structure connected to the bone, but the other end you are not seeing, think about it as a muscle. Trace it. Trace it in short axis, and if it goes and continues into a muscle, understand that that's a muscle. And how do you differentiate between nerve and tendon? Nerves are also fibrillar structure, tendons are also fibrillar structure.
Nerve is anisotropic.
Attachment.
Yes, tell me, Saket.
Nerve is anisotropic.
Excellent. Tendons elicit anisotropy. Nerves do not elicit anisotropy. So how do you do that? See, you just keep, for example, you see this here. That's your carpal tunnel area, right? I place my probe here. I am confused. Where is my nerve? So I tilt my probe like this. So what will happen? The tendon will become black and white, but the nerve will remain the same. Got it? So tendons elicit anisotropy, and then that can be used to identify whether we are dealing with a tendon or we are dealing with a nerve. Then the other way of identifying the nerve is you trace the nerve up. Whenever you're confused, you trace the nerve or a tendon up. When you trace it up, what will happen? The tendon will convert into the
muscle.
muscle, but the nerve will just dive in or dive out. The caliber will not change. So I think I'll just show you two more slides and finish it. So this is a bone, shoulder, humerus, and on top of it is this is the tendon which is coming and attaching. Now you need to understand, this is very important. That is why I'm telling you that this is the footprint. What is a footprint? Footprint is the area where the tendon attaches to the bone. So this is the footprint. Always imagine the tendon as a three-dimensional structure. Now, see, this is the shoulder, and there's the tendon coming, right? So now, this is the footprint. This area is the footprint. Now, if it tears from the footprint, it will retract. And at the footprint, mostly the degenerative changes occur. Getting it? Because osteophytes occur here, all these things occur here. So there occurs degeneration and it involves the footprint. Proximal to the footprint is the articular cartilage. So this is the articular cartilage. Where the footprint finishes and where the insertion starts, there is a small area where there's nothing, which is known as the bare area. Okay, neither there is synovium nor there is tendon insertion. Always remember the synovium is never under the tendon insertion. It is proximal to the tendon insertion. Are you understanding what I'm telling you? No? See, articular cartilage. Articular cartilage is superimposed by the capsule, isn't it?
Hmm.
So there is capsule here, no? The capsular attachment. Now the capsule has got two parts. The fibrous part and the synovial part. The inner part is the synovium. So that is why whenever there is fluid effusion, joint effusions, what happens? Fluid comes here.
Barabar.
Barobar?
Yes.
So you need to understand where is the capsular attachment. So capsular attachment is proximal to the anthesis. If you open up the anatomy, please go back and open up your anatomy rather than opening up ultrasound and understand the capsular attachments, because it is within the capsular attachment that the effusion occurs. Okay. And on top of this is the bursa. And this is a subdeltoid bursa. There is the subdeltoid subacromial bursa is the same thing. And I keep seeing so many people posting on for social media in which they show yahan pe, they keep the probe here and they show that it is a subcoracoid bursa. No, this is a subdeltoid bursa when you keep your probe here. Because the deltoid muscle, see where is the deltoid is still here. Feel your deltoid. Anything under the deltoid is subdeltoid bursa. The subdeltoid bursa is extending from here to posteriorly. So that's one entire bursa. Okay. See this. What is this? This is the calcaneum. See the normal tendon coming and attaching onto the lower third of the calcaneum. Can you see this attachment here? The upper third of the calcaneum is devoid of any attachment. So there are different things which can be manifested as pathological manifestation. That could be tendinosis, calcific tendinosis, tendon tears, sprains, bursitis, synovitis, enthesiophytes, effusion, joint chains, etc., etc., which needs a separate class altogether for discussion. Any questions till now?
No, ma'am.
No questions?
Now everyone is, I think, feeling
It's all clear?
Harshita.
I think I've
No one has the energy. You have the extensive energy, Harshita. Hats off to you after coming from US, taking so much with the
Chalo.
enthusiasm.
So no questions, right? We'll
Indeed.
talk about the pathologies maybe in some other class.
Yes,
Okay.
yes,
Okay.
yes.
Okay. Good night, everyone. Thank you for being
Yeah.
so
Okay.
patient.
Fantastic class, Harshita. Yeah.
Only
Thank
one
you.
question is there, ma'am. Excuse me.
Yeah, please.
Uh, if I in the initial stage, if we buy probe, linear probe with a frequency of 5 to 15 and low frequency probe of 1 to 5 or 2 to
Not
5.
needed. Not needed. You should have a standard probe of 9 to 11 megahertz. That is its linear probe. The moment you go to 5 to 15, you are becoming into low frequency to high frequency. And the other probe you should be having is of 3 to 7 megahertz. 3 to 7. So that covers everything. The reason why I'm saying this is the broader the frequency you take, the more money you have to put in. And the more frequency if you take this is an extraordinary frequency which you're talking, right? Extraordinary frequency means they will have to procure it and that would be much more costlier. Always when you are starting with a machine, always buy a linear probe which is 9 to 11 megahertz and a convex probe which is of
Curvilinear.
3 to a convex or curvilinear probe 3 to 7 megahertz, 6 megahertz.
Yes.
That would cover the entire thing. And if you've got more money, then put your money into the hockey stick probe.
Okay. Okay.
Okay.
Okay, ma'am. Thank you.
Okay, guys. Good night. Take
Good night.
care.
You.
Good night.
Excellent.